I want to welcome you to the webinar, Understanding Prolapse, What Your Doctor Didn't Tell You. My name is Dr. Nicole Cozean. I am a pelvic floor physical therapist with a doctorate in physical therapy, specializing in pregnancy, postpartum, pelvic pain conditions, and all pelvic floor disorders. We have a clinic in Orange County, California, which I'm hoping a lot of you are actually local to Orange County. I want to say hi from beautiful OC. We have a clinic in Laguna Hills, California. We're right off the 5, off of Cabot Road. That is only pelvic floor. So we do treat men and women because men have pelvic floors too. But we have 7 full-time clinicians, all dedicated to helping anybody and everybody that has any pelvic floor condition. And one of the things that we treat a ton of is prolapse. And so I hope that we are going to educate you on what prolapse is, what the common symptoms are, and surprise you potentially with how just interrelated everything is around prolapse with other things, other pelvic floor dysfunctions, as well as things like back pain and weak abdominal muscles and things like that. I think that once you kind of see that it's actually a bigger picture, you'll understand why pelvic floor physical therapists are actually some of the first people that you should be contacting when you have a prolapse. So while we're just waiting for a couple more people to join here, I want to just I always want you to know who you're learning from. Like I said, my name is Dr. Nicole Cozean. I have been practicing pelvic floor physical therapy for 20 years in and around Orange County. I went into physical therapy school. I went to Chapman University in Orange and graduated. And my first job was at Hoag Hospital. For those of you local, you guys know where that is. I actually started the pelvic floor physical therapy program at Hoag Hospital about 20 years ago. I worked there and grew that program for 5 years, worked with some of the top leading urologists, urogynecologists, sexual medicine specialists at Hoag for 5 years, grew that program, left there to join another one of my mentors in working solely with people with pelvic pain conditions. As a sidebar, I wrote a book called The Interstitial Cystitis Solution and really got into pelvic pain conditions. So then I opened my own practice called PelvicSanity, which is located in Laguna Hills in Orange County. And I have been practicing here with PelvicSanity for almost 10 years. We'll have our 10-year anniversary in April. So none of this stuff is new to me. I have literally heard it all. But we have a really awesome team here. Like I said, 7 full-time clinicians. They're all mentored and trained directly with me. Another note, we also teach and train other pelvic floor physical therapists around the country through both another educational platform called Pelvic PT Rising and through a conference that I started called Pelvicon, which brings, and the reason why this matters for prolapse is because I bring leading pelvic floor physical therapists in the world to Pelvicon to speak and educate other pelvic floor physical therapists. One of those people is a good friend of mine who has now spoken at a bunch of different Pelvicons. She's the world's leading expert in pelvic floor physical therapy for pessaries, which is a prolapse conservative treatment, and pelvic floor physical therapy treatment for prolapse and stress urinary incontinence. So you are learning directly from courses that we've taken from her. And we have people that have been trained at PelvicSanity with the world's top leading most person in that field. So you're in good hands here with the amount of education that we have. All right, now on to it. I'm sure you guys are all excited to learn a little bit of things. And we're going to go over a little agenda here today. I'm going to go, what is a prolapse? Who gets prolapses? What are the common symptoms? What are some not so common symptoms? And then we're going to go over treatment. We're going to focus a lot on different treatment strategies. Many of you have probably heard, and you can say me in the chat if you can, if you've heard this, that really, if I have a prolapse, it's either like I just have to live with it, or surgery is my only option. Has anybody heard that sort of phrase, those phrases from your physician in one way or another? Type me in the comments if that's been you. It's a very common experience that and we're going to go over why that is and why pelvic floor physical therapists actually have quite a different view of the pelvic floor and the organs of the pelvis than most doctors do. And it's not that those doctors are wrong or anything like that. It's just that they have a very narrow view of the treatment options available, right? So a little bit of, what's the phrase when all you have is a hammer, everything looks like a nail. So when, with all, sorry, something just happened on here. Someone just joined this. Can you guys just see me, or can you also see Jesse here on this? Perfect. Just me. Wonderful. Just weird on my view. I don't. Thanks. All right. So anyways, one of the big things is that, when what I was saying about physicians is when, you have a hammer, everything looks like a nail, right? And so really at the end of the day, surgeons, OBGYNs and urogyns that have, that can diagnose prolapse, their treatment options are relatively limited outside of surgical intervention. And surgery is not indicated for everybody. It is sometimes a very valid option for folks, but there's a lot of in between. And that's where pelvic floor physical therapists come in. And so we're going to go over a big chunk of today. We're going to go over what we actually do, how we look at the system of your pelvic floor and body different than a doctor does, and how we can help you even if you end up choosing surgery. Why pelvic floor physical therapy might be a really great option for you to enhance your outcomes for that surgery. And many people don't need to go on to get that surgery either. So that's what we're going to do. And then we're going to leave some time for questions at the end. As you go along, you can ask questions in the chat there, and I will do my best to, if I don't answer it right away, I will get to it. So here we go. What is a prolapse? I think prolapse is a very scary word. If someone talks to you about like what it is, and it talks about your organs dropping, if you would put in the chat a little bit about what you've heard prolapse is, I would love to just hear what you've actually heard it is. And it can be scary, right? Oh my gosh, why is my bladder falling out of my vagina? And that's actually not really what happens. There are a couple different types of prolapses, one of which something can actually be coming through the vaginal canal. But a lot of times what happens is that, so if you have your organs all sitting here, I'm just going to give you a little overview of what this looks like. Okay, this is your pelvis. Everything you see in red here is your pelvic floor. And in this big bowl is where your pelvic organs sit. So it actually looks a little bit like this. It's a tight fit in here. All right. You have your bladder, you have your uterus, if you have a uterus, and then you have your rectum. If you've had a hysterectomy, you may have your ovaries, but your uterus removed. You could also still have the cervix and or the vaginal cuff. So you still have something in the place of where the uterus was. It just might be very much smaller. So if we take out where these organs are, they're all close together. Okay. And so if this is your vaginal canal right here, your bladder sits here. There are both muscles and what we would say like sheets of fascia that are in between each layer. What happens with a prolapse is that either the muscle support or the fascial layers are disrupted to the point where this shifts a little bit. So this bladder could be shifting downwards just a bit. Your uterus could be just down, lifting down. This part of your uterus could be pressing down on your bladder, or this part of your rectum can be moving here. Now, that is not your organs falling out of your cavity. So this is, I think, hopefully this will make sense. This is a vulva. We're going to go over female anatomy here for a second because that's mostly what we're talking about, although men can get rectal prolapses. So what we have here is your vulva and vaginal canal, okay, with the organ sitting on top. So what actually is happening is your vaginal canal is right here. But what's happening here is that your bladder is essentially just pressing down on the vaginal canal so that if I looked into your vaginal canal, what I would see is not your bladder, but I would see this coming down here. Okay. So so that would be what we call an anterior wall prolapse. So the bladder sits here. It dropes down just a bit. And what we see when we look in is this. Now, the degree at which this is happening is where we get the grades of prolapse. And we'll go into that here in a minute. But anatomically, I kind of want you to just get this picture. It's not that if you ever were to look at yourself with a mirror, it's not that your bladder is like coming out of your vagina. It's that bladder is pressing down on the wall of your vagina and it is forming a little bit of a bulge, but that's what we would see. Conversely, remember here, we have your organs sitting on here. So on the top part is your bladder. On this part is the rectum. Okay. So your rectum can be doing the same thing. So your bladder can be here. Your rectum can be here. So when I look in, I would be able to see the bottom part coming a little bit towards the opening. All right. Again, it's not that your rectum is coming into your vagina. It's just that the wall of your vagina is a little bit lax and it's allowing the rectum and or the contents of the rectum, which is poo, to sort of pocket in here a little bit. So we'll go over what that is. That's called a rectocele or posterior wall prolapse. So wall of your vagina, rectum protrudes in a little bit and can feel like something is bulging or heavy in that vaginal canal, right? Or is everybody with me? Say with me or with you if you are with me in the comments, please. So that is I hope that helps, right? A little bit about what this actually is. Now, I did talk about uterus. This is if we're here, hope this visual is helping. So we're like this, right? We talked about the bladder. We talked about the rectum. What happens if your uterus is actually drooping back a little bit or down? Okay, what ends up happening is that when I look into the vaginal canal, what I might see is your cervix, drop this, your cervix pushing forward. Now, this is something where like I can actually see your cervix lower in the vaginal canal than it might otherwise be. All right. Now, a lot of people are confused as to why this happens. And the truth is that there's two major supports of your pelvic organs. There are essentially ligaments and fascia, similar to how we have ligaments in our like ankles and knees and hips. There's ligaments and fascia, and there's muscular support. Okay. The muscular support is your pelvic floor, right? If we didn't have your pelvic floor, then there would be nothing to like, all of this would be blank and everything would just sort of be like drooping down. There's also fascial support. And this is where physical therapists and physicians get a little bit muddled. So physical therapists, our biases is to believe that everything is muscular related, and physicians tend to believe that everything is fascial related. The reason why physicians tend to immediately go to surgery is because, and it's true sometimes, that anybody that has a prolapse, just like a grade 2 or so, can have an actual disruption to the fascial support, which means that any amount of Kegling and any amount of squeezing your pelvic floor is actually not going to be as helpful as someone who doesn't have that fascial issue. There are ways that physicians can look and see, can that is and measure how bad is that fascial defect. Again, if you have that though, their lens is, well, let's fix it. Okay. And our lens is, how can we support it in different ways with pelvic floor, with other things like pessaries, so that we can see, can we get the symptoms down enough so that we don't have to go to such great lengths where surgery is not our only option. There is high level of evidence, and both in the literature and anecdotally, that we can get your symptoms to be down enough so that surgery doesn't have to be your only option. Now, as we talk, we're going to talk a little bit more about treatments here in a minute, but I do want to hit on this because when you guys submitted your questions, you had a ton of questions about confusion and fear around surgery decisions. Like, this is my only option. I just have to wait for it to get bad enough so surgery is available to, like, I have to wait until it gets bad enough so that surgery is like the option for me, which basically kind of sucks, you guys. Right? It sucks to have to be in a situation where you're like waiting for it to get bad enough to do something about. So that is what is very interesting. We don't want that. The other thing to know about, and this is very specific to prolapse repair surgeries, they have one of the highest failure rates of all urogynecological surgeries. In the literature, meaning when they study these things, and it varies and it depends on what kind you have and the type of surgery that you have. So there's a lot there. But in general, surgery failure rates are between 30 and 50%. Okay. Now, that is sort of sobering. It's like, well, now you're talking to me about waiting until I get bad enough to have a surgery, and then 30 to 50% chance that that surgery will fail and I'll still end up with a prolapse, perhaps even worse than I started with. That's sobering. As physical therapists that specifically treat prolapse and pelvic floor conditions, we truly believe that making sure that addressing the reason why you have prolapse in the first place, or treating why a prolapse is exacerbated, is key, regardless of whether or not you're going to have surgery. Because the way that we treat is very similar, even if surgery is and ends up being the best fit for you. We can't forget that there's reasons why prolapse is worse. Things like constipation, the way that you are, what we call in our physical therapy world, managing pressure. But what that means is how we're breathing, how we're lifting, how we're sneezing, how we're coughing, all of those things that can be placing more stress and pressure downwards that makes prolapse symptoms worse. Those things can be mitigated to either help your symptoms go away or to make your surgical outcomes potentially better, because we would be eliminating any sort of reason why, or a big reason why surgeries fail in the first place. And that's huge. If you don't take anything away from this, it's that even if we end up coming to a conclusion together, you come to therapy and we end up working together and we still both decide that, like, gosh, surgery might be your best option. Your symptoms are still really sucky. They really are bothering you. We've done all of the things that we know how to do, and it's still like that. You didn't fail PT. What you did is you prepared the best you possibly could for the best surgical outcome. And so that's one of the things, the ways that we look at this so differently. If you think of like an athlete that goes into for a surgery, you talk about prehab. They do a lot of things before to make the surgical outcome the best possible. And we can help you with that at Pelvic Floor Physical Therapy, even if surgery ends up being your choice. Now, we can talk a little bit about what that looks like and how we make those decisions in a second. But it said we have a couple of questions here for me. Degrees of prolapse are different every day. This is a great question. So how does a physician or physical therapist correctly grade the level? This also goes into how we as pelvic floor physical therapists differ from how we look at the different grades of prolapse. So in terms of prolapse grades, prolapse is graded from grade 1, 2, 3, and 4. Grade 4 is where the actual protrusion of whatever this is actually out of the vagina. Grade 3 is where it comes to the opening, and grade 2 is about halfway, and then grade 1 is like sometimes just a little bit. So the most interesting fact I think that I've seen in the clinic that is very well established in the literature is that degree of your symptom bother, meaning how much does this bother you, and the degree of prolapse are not correlated. So someone could have what would be considered to be a very small prolapse, grade 1 or even a grade 2, and have a significant amount of symptoms. And there are people with grade 3s, and 4 is pretty obvious that it's like a problem, but you could have someone with a not great grade 2 or a grade 3 that has almost no symptoms, that didn't even know they had a prolapse. So what that tells us is there is something else going on with the way our body is perceiving that warrants treatment, right? So the real question is, when you're deciding on whether surgery is an option for you, is how bad is what we call the anatomical prolapse? Where is the actual organ sitting, and how much is it protruding into the vaginal canal, and what structures might be having a problem supporting that, right? So there's the anatomical grade, and then there's also the symptom bother. What is it actually causing, right? So for many people with prolapse, it also causes it can cause urinary retention. It can also cause urinary incontinence. It can cause constipation. It can cause incomplete emptying of your bowels. It can cause fecal incontinence. Like, there's a wide variety of things that go into the symptom presentation. So we can help a lot of the symptoms, and maybe even, but we might not change your anatomical grade, but we make your quality of life 10 million times better, to the point of, well, we don't even need to think about surgery, because having a prolapse inherently is not dangerous. Okay, that's the other thing. This problem that I was talking to you about is not dangerous. It's not like having a twisted bowel, or you're not at risk for any huge thing, potentially UTIs in some cases, but we can mitigate that with a lot of other things. So it's not inherently dangerous. So the real thing is, well, how bad are your symptoms, and how much is it affecting your quality of life? And can we help with that? And pelvic floor physical therapists are willing and able to help you do all of those things to try to get the symptoms down as much as possible. There's a little bit of controversy and a little bit of evidence in the literature that is some things say one thing, some studies say other things, on whether or not we can actually change anatomical grades of prolapse. Meaning, let's say you have a certain amount of grouping of your bladder, for instance. Can pelvic floor physical therapy actually reduce the prolapse grades? And I will say it depends. It depends on the grade of prolapse. It depends on your anatomical makeup. It depends a little bit on your genes, not like glue genes, but like genes like GENES, of what your fascia is made up like. And it depends on if you actually have an injury to that fascia. Let's say you have a birth injury to that area. But the point is that if we can get your symptoms down so it doesn't bother you, you might not be wanting or needing that surgery at all. And again, even if you do end up choosing that because you get to a point where it's like, this does really bother me, and we've done all the conservative things and I still pisses me off that I have it, then we know that we've done everything possible to mitigate what those symptoms are. So my urogyne measured my prolapse while I was under general anesthesia and said it was a stage 2. This is where surgeons look at things very differently. You can measure and do what's something called a POP-Q, which is the anatomical measurements, where they look at 9 different measurements of your organs. If it's under anesthesia, which means you're laying down somewhat with your legs up, usually in stirrups for a gynecological procedure, that is very different than what your body's actually doing when the entire system and your brain is sort of online, essentially. So your pelvic floor muscles at that point don't have any support if you're doing it under anesthesia. And you're also not standing to see like what else happens when your glutes are on and your other leg muscles are on. But there's still gravity, right? So it's an interesting thing because it's anti-gravity, but we're functioning in gravity, right? So the real question is it better or worse than a stage 2 when you're not under anesthesia? So that just goes to show too that that's a completely valid thing for a surgeon to do. And it also doesn't mean a ton for your actual day-to-day symptoms. So I would say, I don't care that you have a stage 2. I would want to see what you actually look like in the clinic. Okay, so there's that. So we went over what a cystocele is, what a rectocele is. There's a couple of other different types. We went over what a uterine prolapse is. Some people have asked, can I still have a prolapse even though if I've had a hysterectomy? The answer is yes, because what happens when you have a hysterectomy is they obviously take out the uterus. Sometimes they'll take the cervix. Sometimes they'll leave the cervix. But bottom line is that there's something still there. So they either will sew up what they call the end of the vagina. So they'll sew up the vaginal cuff, and that can still prolapse a little bit into the vaginal canal, or the cervix can still prolapse into the vaginal canal for a uterine prolapse. So you can still have we call it a vaginal vault prolapse if you don't have a uterus. So we talked about what an anterior wall prolapse is, what a posterior wall prolapse is, what a uterine prolapse is. And there's a couple of other different types that are actually relatively rare. And so if you have those, you can just reach out to us and we can the treatment, everything we're talking about is still very much important or is still very much relevant to this talk. So who gets them? A lot of people. So there is some studies that show that up to 40 to 50% of people have some form of prolapse that's actually could be graded stage 1 or greater. I already talked about the difference between symptoms and actual anatomical grade, which is can make you feel a little bit better too, because just because you have a lot of symptoms doesn't mean your prolapse is that much worse. And we talked a little bit about why they happen. Either the muscular support is gone, some of the fascial support is gone or decreased, or both. And then you can also have a birth injury where as the baby comes through the birth canal, you end up having a disruption to that fascia and or of the muscle. So if you've had a perineal tear, sometimes the muscular support of your organs and pelvic floor is also lacking, and that can create the perfect storm for a prolapse as well. I will hit this question about pessaries here soon and how to evaluate for your physical therapist here in a minute as well. So why do they happen? They happen because things are complex down there, and because the muscular support and the fascial support can be disrupted. The other reason why prolapses happen is because we might have a pressure problem. So I have a balloon here. It's full of air. This is like a representation of what it would be if I was standing up, right? So we have our pelvic floor here. We have our diaphragm here. And what I want to talk to you about is if you are, a lot of people with chronic allergies or chronic coughs will be coughing, and it puts this pressure down onto the pelvic floor. Or if you lift and you have a breath strategy that is suboptimal, meaning you are holding your breath when you lift something heavy or hard, or you have not great form at the gym or whatever, then you can be producing a lot of downward pressure onto the pelvic floor and onto your pelvic organs, right? So a lot of what physical therapy treatments are is to help you to better manage this type of pressure around your diaphragm. So hopefully that visual is helpful. If we have something that is tight around here, so even something like tight pants, I'm not saying that tight pants can create a prolapse, but what I am saying is that it changes the way we distribute pressure and put a lot of pressure downwards onto the pelvic organs and pelvic floor. So part of what is going on here is basically helped by pelvic floor physical therapists assessing your entire body and helping this whole system to be much more efficient, and the pressure that would be going down to your pelvic floor dispersed around the entire canister. And it depends on what kind of activity you're doing. It depends on your glute strength and your leg strength and your arm strength and your back strength and all of that, on how that works for you. But we can certainly help you with all of that in physical therapy and assessing for you what strategies are actually maladaptive that are creating too much pressure down versus which ones are actually helping support your pelvic floor. So that's why a lot of times we'll teach people how to do a pelvic floor contraction to sort of mitigate that amount of pressure downwards. Now, talk to you about Kegels in a second. Kegels are not for everybody, but they certainly can help if they're prescribed correctly by your pelvic floor physical therapist, and they don't have a tendency to be too tight, your pelvic floor muscles. So if you have anything else that has a tendency to create tightness in the pelvic floor, that can also inhibit your pelvic floor's ability to counteract the downward pressure. And it can also create symptoms of prolapse. It can create, if you have pelvic floor dysfunction, it can create vaginal heaviness, feelings of vaginal dryness, painful intercourse, incontinence. All the things that you think might be because of your prolapse can actually be because of pelvic floor dysfunction. So that's one of the big things that us as pelvic floor PTs will actually look for. Be like, so you're having these symptoms of prolapse. Awesome. What does the structure actually look like? What is your pelvic floor actually doing? And what is this entire system doing? And why are we having that pressure downwards? And we have to do all of it, treat all of it to help mitigate, to make sure that the prolapse doesn't continue to get worse, and also put you in the best position possible if you end up going to have surgery. Because if you had surgery and you still have a breathing pattern that puts a lot of pressure down on your pelvic floor, that is going to further stress the surgical site and lead to that 30 to 50% failure rate that we have. All right. So hopefully that good visual, you guys. Does that help to see like why we care about everything outside of just the pelvis and pelvic floor? Give me like a thumbs up if that was helpful. If this visual was helpful. If this visual was helpful. I feel like sometimes when we understand a little bit more about what's actually going on, I hope what's going on is that now you can all of a sudden think about all of the ways that we can intervene that aren't only surgery. Okay. Like this is huge. This is why we love what we do, because there's so many options and individualized options. So that's like a one size fits all is not treatment approach is not appropriate, right? So if you've ever been given, oh, here, just do your Kegel exercises, like that's like not it, right? That's not why we have doctorates in this stuff, okay? So that is that. Now, a couple of different things that we want to talk about too. So we went over some of the treatment stuff. We're going to do a little bit more. We're going to talk about how we specifically evaluate it. We talked about the surgery options. Now, let's talk about some conservative measures or conservative treatment options. Pelvic floor physical therapy is a big umbrella term. So what are we actually going to do in pelvic floor physical therapy to help you with these symptoms? One of the first things we're going to do is take, especially at PelvicSanity, is take a full body approach. So this is going to go back to someone asked the question here, how do we assess the skill and knowledge of a pelvic floor physical therapist? I've been to two, one was not helpful, and one did not seem very knowledgeable compared to the other. So important that you get the right help, because we see a ton of people at PelvicSanity that have been to other pelvic floor physical therapists in and around Orange County. And I can tell you that unfortunately, a lot of the times, if you're doing the wrong types of interventions or something that's not going to be effective because you didn't get a proper evaluation, then you could be working with someone for months. And it's like, well, but that wasn't the right strategy to help you. So of course it didn't work, right? Of course it didn't work. So it sucks that happened, but it's also empowering to be like, if you get the right fit for a pelvic floor physical therapist that actually knows what they're doing, that takes a full body approach, that specifically has been taught on how to manage prolapse symptoms and give you potentially conservative options like pessaries, we're going to talk about here in a second, like we have at PelvicSanity, then that's where it's at. That is where it's at. Now, if you don't achieve your entire goals with a place like us, then we can be much more confident in, conservative management really didn't work the way that we wanted it to. It set you up for a great surgical outcome. And now we know what we're working with. Maybe we mitigated 50% of your symptoms, but these 50% are still here. They're still very bothersome. Now we pick the surgeon to do the surgery, and you have worked really hard to make sure that surgical outcome is going to be great. So that's why it's super important. Okay. So full body approach, meaning we're going to look at you from head to toe. I care about how your rib cage is. I care about how you're breathing. I care about your back. I care about whether or not you've had back pain. I care about if you've had any compensatory activities or strategies to offload your back because your back has been a problem. And now that's creating that downward pressure situation and contributing to your prolapse symptoms. As an example, a lot of times people with back pain have weak abdominal muscles. And if you have weak abdominal muscles, then are we creating strategies that actually are trying to stabilize your back, but actually creating downward pressure down onto that prolapse? So we look at the full body. We look at how strong your legs are, how much they are, we say like how much they are managing impact. So like walking, running, doing activities, going to the gym, all of that stuff gets translated up through the pelvis. And we look at how you're moving and how efficiently your movement is and how efficiently we're doing with all of this during those activities. A lot of times people are told, oh, well, you're a runner. Sorry, you have prolapse. You shouldn't run. And we are like, well, we at PelvicSanity are much more like, cool, let's keep you running. How are we going to help you to run with that, with helping your symptoms and also mitigating the risk of running, that prolapse is going to become worse with that. So we have that. So we have full body. We have an internal assessment of your pelvic floor musculature is extremely important with looking at why and how your body is managing this prolapse. Okay, so we can do a vaginal assessment. If you have a rectocele or any bowel symptoms, we can also do a rectal assessment to see what is happening. Remember how I was saying that a lot of times it's like if you have a rectocele, this part is your rectum is coming in on your vaginal canal, right? But there's pelvic floor muscles that attach to this area as well that can support your external anal sphincter. And we need to look at what those actually are so that we can see what does the pelvic floor actually feel like on these outsides, and is there a mismatch in strength to what it needs to do? Are we able to relax it? Are we able to do a efficient pelvic floor contraction? All of those kinds of things are extremely important to assess to make sure we individualize your treatment. And this is the thing that PelvicSanity does. And what you should be looking for in a pelvic floor physical therapist is that we do both a standing assessment and a dynamic assessment. So a little bit to that person's point about, well, I was assessed by my urogyne in supine, meaning or on the table, right? That person happened to be doing it under anesthesia. But even if you go to your OBGYN, they're looking in with the speculum and they're saying, cool, yes, you have a prolapse. They're measuring in their whatever way that they do. They have a specific measurement thing. And then they're saying, yes, you have a prolapse. It's like, well, great. But that can significantly change, sometimes for the better, sometimes for the worse, when you're actually standing up. So this is also where sometimes the mismatch is like, I feel like I have a prolapse. You go to your gynecologist, they look, they're like, it's a grade 1. It's not that bad. Actually, in parentheses, I don't know what your problem is. Anatomically, it doesn't look that bad, but you can feel like it's really bad, and it can change and fluctuate throughout the day. Why does that happen? That is something that your physical therapist can evaluate for you. Is it better in the morning? Is it worse in the morning? Does it get worse as time goes on throughout the day? What activities might exacerbate those symptoms? Do you also have concurrent painful intercourse or trouble with constipation or feeling like you can't empty your bowels, or any or all of those things? Help us to get a picture of what is your pelvic floor and musculature actually doing there. Okay, so we do an assessment standing. It can be extremely different when you're standing, and it can also be different when you're doing the activity. If you told me, I feel like I'm having a bulge when I lift my baby, I'm going to be like, cool, here's a 15-pound weight, or we have a carrier at the office and be like, put a 15-pound weight in there. That's how much these darn things are. And now I want to feel what's happening in your pelvic floor when you're doing the activity. Okay. Because it gives us information on what we need to treat in order to make that activity more efficient, to make sure that the downward pressure is not as much. And that can be different for literally everybody. So somebody asked up here, well, what are your top 3 exercises and breathing techniques you'd recommend to mitigate downward pressure? Well, I'm not actually going to answer that. It's going to be frustrating to you, Kelsey, but it depends. And that is why you need an individualized assessment. It depends, because what is important for one person is not important for the other person. And how you're recruiting your pelvic floor is different than somebody else. And what activity you're doing around this downward pressure. So there is no the best exercise for prolapse, which is contrary to what you might see on social media, but it matters for all of the things. So yes, perfectly good. That makes sense. I know some people are like, nah, why isn't she just answering my question? So hopefully you can understand now the complexity of that and why it makes us want to shrivel up in a hole to be like, I don't know, because I don't know your situation, right? Okay. Other conservative things that people are very confused about in our questionnaire that we wrote is like, how does a pelvic floor PT know anything about these things? These things are called pessaries. These are all different types of pessaries. These ones are called cubes. This one's called a donut. This one's called a ring with a knob. This one's called a disc. So pessaries are things that you insert into the vaginal canal, and they look big, but you really cannot feel them. About 2/3 of your vaginal canal actually doesn't have any sensation. So they go far up enough so that you shouldn't be able to feel a pessary, even if they're this big. I know it looks crazy. And these are meant to help support your fascia or the organs, the stuff that holds up the organs. They're supposed to make your pelvic floor muscles and your entire pressure system more efficient. Okay. Now, it used to be that only physicians would be able to fit you for pessaries. Now it is something that goes under the purview of pelvic floor physical therapists if you've been trained. So why I was telling you guys about how I do Pelvicon and all the things is that this clinic in particular in Orange County has some of the only therapists that are able to fit pessaries. And we've learned from an Australian physical therapist who is the world most leading expert in pelvic floor physical therapy and treatment of pessaries and prolapse. So that's kind of cool that you have that in the area. These are used for different types of prolapses. So some people do better with cubes. Some people do better with rings. You can get one that doesn't have this knob. I took a whole 4-day course on what these do and why. And so I can't go into all of that here. What I can tell you is that our therapists are trained in understanding when a pessary is going to potentially help you and when it might not. And if you've been fit with a pessary, many physicians don't even fit the variety of pessaries. A lot of them will only fit rings, which are not appropriate for a lot of the population. And that's frustrating because you're thinking, well, I go to a doctor, shouldn't they know? And the reality is that they don't actually get taught a lot of this stuff. And they're learning actually a lot of times, if they don't get taught it in their residency or fellowship, then they get taught it by the vendor of these things. So they'll be like, oh, well, you just need some ring. And then you shove a ring in there and see if it works. Instead of actually doing a lot of the assessment pieces with the standing assessment, the dynamic assessment, and what that looks like, and the measurements that we can do to see, are you appropriate for a ring? Are you going to do you need a knob on the ring to help with your urethral pressure? Because sometimes if you support the organs, you actually unkink the urethra and you can actually create stress urinary incontinence. So all of that is to say that this is relatively complex to decide whether or not you need one. But the cool thing is it's a really awesome conservative option for folks that need support, hate that feeling, but still want to exercise, that aren't ready for surgery, that are early postpartum. And there have been some evidence to show that putting this in can actually help with during the healing process of the 18 months postpartum, so that the fascia can actually heal and sort of contract back to its normal size if it wasn't actually torn during childbirth. Like, huge. These things are so relatively easy to manage. There's a few different things that we can help you with that, but a lot of physical therapists are not trained in pessary fitting. And so they resort to things like Kegel exercises when it might not be a muscle issue that you have your prolapse. It's one of the reasons why we need to assess and see. Julie says, this is so good to hear. I have a ring with the support for 3 years, but feel it needs changing to something different, but not getting much help. Yes, totally. We can totally help with that and see. And maybe the answer is that you don't really need anything different. You just need different strategies, but your anatomy can change as well. So that if you were fit a long time ago, the size of the pessary may be different. The type of pessary we might need might be different, and all the things. Charity, that's a loaded question with how different opinions of how long to leave a pessary in. What's your recommendation? It depends on the type of pessary, and it depends on a lot of stuff. So I got to leave it at that. Sorry. Some pessaries need to be taken out every day. Others can be left in for 3 months. The reason why you've heard different recommendation is because it depends on what type and what it's for, and if you are actually able to physically take it out yourself. most of our patients at PelvicSanity, we teach how to manage them at all. When I used to work at the hospital, for some folks that didn't have the dexterity to actually manage a pessary themselves, they needed to go in every 3 months and have it cleaned and whatever with their physician. But that was before pelvic floor physical therapists were able to do pessary fittings in the first place. Okay, so I know we're getting a little bit long here, but I hope this is helpful. We're going to do a little summary here in a second. Just want to make sure I get to all of your questions. Best pessary for someone with pelvic floor pudendal nerve pain. This leads me into prolapse very rarely is the only thing that's the problem with the pelvic floor. Okay. Have I fit pessaries with people with interstitial cystitis, pudendal nerve pain, pelvic pain conditions? Absolutely. Is it always my first go-to? No. What we need to do is make sure that the pelvic floor itself has the ability to have something in the vaginal canal without irritating. And that is huge. And that's huge. Denise, the name of the therapist or company you trained under, it's called Women's Health Training Associates. Her name is Taryn Hallam. She is from Sydney, Australia. And that's that. What else? Okay. Someone says, does PelvicSanity help to treat rectal prolapse? Was told surgery would be needed. This is where the nomenclature really matters. So we talked a little bit about a rectus seal, right? Which is a vaginal wall laxity essentially here, that where the rectum is coming like this. Now, a true rectal prolapse is where the rectum itself is coming out of the anus. So we can treat both, but there are very different reasons and pathways for that. Can you be fit with a pessary if you're pregnant? Yes, Rose, good question. Yes, you can. And we would need just to make sure that you understood the risks and benefits of that. And a lot of it, we'll just get clearance from your OB. But if you have a otherwise normal, healthy pregnancy and you have prolapse and have symptoms of prolapse while you're pregnant, absolutely, it is appropriate for someone with that. Ooh, Sarah, great question. Do you have suggestions for the hypermobile Ehlers-Danlos population that differ from normal people? Do you see a correlation between pelvic organ prolapse and these conditions? The answer is absolutely yes. So Ehlers-Danlos is and hypermobility syndrome. Hypermobility syndromes it's a connective tissue disorder. There's a bunch of different types of them. They're on a hypermobility spectrum. We actually had a speaker at Pelvicon talk specifically about hypermobility syndromes. We have specialists here that treat those. So yeah, we have to definitely treat that differently. The way that we strengthen y'all is different. Sometimes the approach that we take to that, you have a tendency to really react in terms of a tightening of the musculature to help counteract that connective tissue laxity. And so sometimes we have to do the order of operations of how we introduce something would be different. Pessaries can be great options for those folks, because the reality is that a lot of times just the muscle strength alone or the strategies to mitigate the downward pressure just isn't quite enough. And we actually need that fascial support. And if you're not eligible and a lot of times you guys aren't great surgical candidates, I say that very broadly. Some people are, but that's where these things come in as well. And just the right type of strengthening can be really helpful. What about the Emsella chair for strengthening pelvic floor? I could go off on the Emsella chair. The reality is that we don't believe at PelvicSanity that a passive treatment like the Emsella chair, just sit on this chair and have it contract your pelvic floor for you. I don't think it actually does pelvic floor contractions like we need them to manage prolapse. Number two, it's not appropriate for everybody because nobody needs to be doing 10,000 Kegels a day, which is what the companies claim. And we just feel like it's a passive treatment. So we are usually not into the Emsella chair, especially not without a actual workup from a pelvic floor physical therapist on that. Okay. Great question, Kelsey. You are asking all the right ones. Do changes in hormones throughout a menstrual cycle play a role in fluctuations of prolapse symptoms? Absolutely, they can. I have a grade 3 over a year learning to manage it. Notice sometimes right before my period, it feels very heavy all around the vagina. There's a million different reasons for this. Yes, hormone fluctuations can directly affect this stuff. This is one of the reasons why having genitourinary syndrome of lactation, so postpartum, we're in a low estrogen state, our body's pelvic floor and fascia and vaginal canal and urethra and all of that stuff loves estrogen. So if we're ever in a low estrogen state, either from birth control pill, postpartum, lactating, and or perimenopause into menopause, it can significantly affect how our muscles function. It can significantly affect our fascia. But interestingly, it can affect the sensitivity of our tissues, meaning you could have had and I'm not saying, Kelsey, this is you, but anybody could have, let's say you have a grade 2 prolapse and you're one of those people that had it for a long time, didn't even know they had it, go into perimenopause in a low estrogen state, and now it bothers you more, right? So sometimes things like vaginal estrogen or local estrogen therapy, or considering adding hormone therapy to your regimen can be super helpful in managing prolapse symptoms and making sure that everything is efficient. Now, that's where pelvic floor physical therapists, we can look and see, does your tissue look like it needs estrogen? And do you have any of these other areas where that might need? And then we would refer you to your physician for management of your hormones. So we definitely, that's where we need to like work together with your OBGYN. But a lot of times it's missed by them. And a lot of physicians, and this is, you guys have probably heard a little bit about perimenopause hormones and the black box warning of all estrogen therapy for menopause related symptoms have been removed now because there's research to back up that it's not harmful like we once thought it was. But a lot of physicians are not up to date on all of that stuff. So we are, and we know the physicians that are around Orange County. And so we certainly advocate for that if it's the right choice for you. Okay, started with my 8 months postpartum after my second child. So it makes sense. Low in estrogen, absolutely can. And so the real question, Kelsey, at that point is the prolapse actually worse after your second baby? Or are you just more sensitive to it because of that low estrogen state? And it can be a both and situation. Both, you need pelvic floor physical therapy to help manage and mitigate any symptoms from getting worse, and also needing estrogen therapy. It is not an either or proposition with any of this stuff. It's always both and. All right. Okay. I think we are at an hour now. So I think this is enough information for you to hopefully see. So let's do a little summary. We went over what is a prolapse and all the different types, who gets them. A lot of people. So it's very common, but we say that the symptoms and dealing with the symptoms is not normal. So we definitely want to normalize that you can get help for stuff. And it's not just wait until it gets bad enough to have surgery. That's some bad advice. All right. Symptoms. We went over some of the symptoms of vaginal heaviness, vaginal dryness, feelings of painful intercourse, and all the other pelvic floor dysfunctions that can go along with it. Usually prolapse does not happen in isolation. So a lot of other things can be contributing: back pain, hip pain, painful intercourse, constipation, difficulty emptying your bowels, incontinence. All of those things can be related to your prolapse as well. We talked a little bit about the difference in philosophies and treatments around what your surgeon or your OBGYN and urogyne is going to get versus why we look at the body in a different way and why our therapy options are different to treat the symptoms of your prolapse, even if we can't necessarily change what they would say you have. We can significantly impact your quality of life. I think the biggest takeaway here is that regardless of whether or not your surgery is on the table for you. For many, it's not. For some, it is. Pelvic floor physical therapy treatment needs to happen because that surgical outcome needs to be better than 30 to 50%. And pelvic floor physical therapy can help that. And then I hope that we went over and was clear about what we specifically do at PelvicSanity, full body approach, external therapy, orthopedic assessment, standing assessment, dynamic assessment of your pelvic floor, pressure management, all of mitigating this, keeping you active while we're managing these symptoms, because a lot of times people are also like, well, just don't, if you have more symptoms of prolapse when you lift, then just don't lift. Well, that's not what we want for literally anybody. So our goal is to keep you as active as possible while managing your symptoms. We talked about the conservative management techniques like pessaries that we know how to do here at PelvicSanity. And I just really hope that you guys take away that not all pelvic floor physical therapy is created equal, that prolapse management is a team effort with your urogyn, your OBGYN, and us to work together on what needs to happen for you. We can't prescribe medications. And, we do, although we have a different look at what prolapse is, we definitely can work together on helping your symptoms to get down. The other big takeaway that I want you guys to hear me on is your prolapse is not the end of, like, your prolapse symptoms are not how they have to stay. Like, you don't have to live with these symptoms. We can totally help you to get them down as much as possible. We've eliminated people's pelvic prolapse symptoms. Even if the prolapse is still there, there's still hope that we can get those symptoms to go away to a very manageable level, if not all the way gone. There's so many conservative options other than surgery. If you do need surgery, pelvic floor therapy is the way to prehab for that anyways, and you're going to need it afterwards to help rehab as well. So I really hope that you guys will consider getting to pelvic floor physical therapy. We would love for you to come see us at PelvicSanity. Like I said, we have 7 amazing clinicians that this is their passion to help you guys with stuff. All of them are, I've personally trained all of them. I've handpicked all of them. They're the best, I think, in the United States in terms of what to offer. And so you can definitely reach out to our clinic if this webinar was helpful, if you think that we can help you. And we promise to be honest with you regarding that. Someone asked about how long the treatments last. Totally depends on what we're working with, on how bad your symptoms are, on what your anatomical state is, and all the things, and what other things you have in concurrence with the prolapse, so incontinence, painful intercourse, all those other things. So it very much depends, but I would say it's not a one-stop fix, right? This is not like we don't have any magic wands here that are like, cool, you came in one time and you're done. I would say to plan for at least 3 months of therapy. And I hope you can see why we would need to look at all of those different aspects and avenues to make sure that we can get your symptoms to go away. But the key, you guys, is that your symptoms stay away. So I hope that this has been helpful for you. If you have any other questions, please reach out to our clinic. We will be sending a follow-up email with all the information about our clinic, how we work, all the things. You can follow us on PelvicSanity on Instagram as well. We'll be posting some other prolapse content on there also. And just know, you guys, that nothing gets easier to treat the longer it's there. Nothing gets easier to treat the longer it's there. So if you've been waiting to go to pelvic floor therapy because, you're just waiting to see if things get better, just come in and please let us help you, because nothing gets easier to treat the longer it's there. Our bodies are really good at compensating for stuff. And even if the symptoms get better by waiting, a lot of times you just need to get that underlying mechanism as to why this is happening in the first place addressed, so that we can have a lifelong healthy pelvic floor region and be able to navigate all of those things through your entire lifespan. Okay. So appreciate all of you for your time. Information on how to access this recording will be up. It's going to be up for a limited amount of time. So if you need to rewatch this, you can. Make sure to be following us on Instagram at PelvicSanity, and reach out to our clinic specifically if you are ready, willing, able to start your pelvic floor PT journey with us. Really appreciate you all. Thank you so much.